getting these. Okay,
Thank you. The committee will come to order. We do have a vote in progress, so this is a little bit unusual, but I have visited with Mr. Levin, and we'll have a looser Gibbons rule in terms of voting, and so we'll go by seniority once we return. So members, feel free to come and go to make sure you're able to make that vote. But Secretary Sebelius, thank you for joining us today for a discussion of the President's 2013 budget. An administration's budget is a reflection of its priorities and vision for the country, and I'm disappointed to say that in reviewing the Health and Human Services budget for fiscal year 2013, I find myself asking, where's the leadership, where's the plan, where's the vision? And despite repeated promises by the administration to strengthen Medicare, to make health care more affordable for all Americans, and to reduce the country's debt and deficits, the present budget fails to accomplish any of these goals. The President's budget lacks guidance about one of the greatest challenges facing the federal government, and by extension, American taxpayers, the long-term solvency of Medicare. The Medicare trustees have made it very clear that Medicare is going broke and that without reform, it will not be able to provide the benefits so many seniors rely on. The Hospital Insurance Trust Fund alone has more than $8 trillion in unfunded liabilities and is slated to go bankrupt in roughly 10 years. With more than 10,000 baby boomers becoming eligible for benefits each day, it's critical that Republicans and Democrats work together to secure Medicare's future and ensure current and future beneficiaries have continued and uninterrupted access to much-needed care. This budget also lacks any assurance or evidence that the health care law will make health insurance more affordable. Last year, health insurance premiums rose by 9% for the average American family purchasing insurance in the workplace. In part, health care costs are directly impacted by regulations and guidance being issued by your department, including government-mandated health benefit packages and exchanges. Take, for example, your government-mandated benefits and actual value and cost-sharing bulletins. If implemented, these bulletins will significantly increase the price of health insurance. Using these bulletins instead of standard regulatory procedures, you've chosen to hide the expected costs of your decisions from the American people. And it's clear that each decision your department makes impacts the price of a monthly insurance premium, and one more mandate, one more service, and one more Washington requirement only adds to the likelihood that costs will increase, not decrease. In addition to the costs consumers bear today, this budget ensures they will face even greater costs in the future. The President's fiscal year 2013 budget contains the highest deficit ever proposed and fails to deliver on his promise to cut the deficit in half by the end of his first term. For example, in our human resources jurisdiction, instead of consolidating programs, ending those that don't work, and making real reforms to others, your budget proposes creating more programs and increasing spending on others by over $10 billion. And how exactly does that help cut the deficit? I'd also note that in addition to the $1 billion already spent on implementing the health care law, the budget requests an additional $1.35 billion in 2013. Even more troubling is the fact the President's budget requests funding for an additional 848 full-time equivalent IRS employees compared to 136 CMS employees solely for the purpose of implementing the health care law. What does it say about health care when you request more than 6 times the number of IRS employees to run it than you do CMS employees? Furthermore, over the next 10 years, spending in Medicare, Medicaid, and Social Security will increase as a percentage of GDP from 9.7 to 11.2%. And Madam Secretary, all this boils down to is more money for Washington to spend, more government employees to spend it, and not a dime in deficit reduction for the hardworking American taxpayer. I'd like to close with a couple of additional points. Madam Secretary, on repeated occasions, members of the House and Senate have written to you and your agency seeking information about how the health care overhaul is being implemented. Too often, these inquiries are either ignored or members receive incomplete and insufficient explanations. Congress, in particular this committee, has a responsibility to conduct oversight of your department. We expect full cooperation from you and your department so we can ensure that taxpayer dollars are used effectively, efficiently, and in compliance with the law. Many Americans opposed the new health care law because they believed it to be an unconstitutional power grab by Washington, as if forcing Americans to buy government-approved insurance and then taxing them if they don't wasn't bad enough. Something I hope the Supreme Court throws out pretty soon. Recent actions by your department prove that Americans have even more reason to worry, that decisions made behind closed doors, in secret, by a small cadre of insiders will impact our most fundamental constitutional rights. So, Madam Secretary, I hope you can provide some additional information for us today on how we address these problems for the American people. I look forward to your testimony. I will now recognize Ranking Member Levin for his opening statement.
I'll shorten my statement and enter a larger statement into the record, Mr. Chairman. Actually, I think we can say it quite briefly. Health care reform is working. The prophets of doom and gloom are being proven wrong. Already, and you'll testify this and welcome, there are successes. For the first time in years, according to the Chief Actuary for the Centers for Medicare and Medicaid Services, growth in national health expenditures will slow thanks to health care reform. It is reducing overpayments and will reform the way we deliver services. We have strengthened, through health care reform, Medicare and improved the benefits. For example, 4 million Medicare beneficiaries saved more than $2 billion last year because health care reform closed the prescription drug donut hole. Health reform isn't just helping those on Medicare, it's helping all Americans save money. My statement, for example, shows what's happened for 86 million Americans in terms of preventive care. 2.5 million young adults have been covered through their parents' policies. Nearly 50,000 Americans are now receiving health care who were denied because of pre-existing conditions. And 3,800 employers have received much-needed help to retain benefits and lower costs for countless retirees and their spouses. So let me just repeat once again, we welcome you, and we think this system, this reform is working. And it was just a few days ago, Mr. Chairman, that you said, I will not rest until Congress, the Supreme Court, or the Attorney General dismantles Obamacare. Health care reform is working. And I think the trouble with its opponents, the real trouble is that they're facing successes for millions and millions of American people.
Good. Thank you. Madam Secretary, we want to welcome you and appreciate you joining us again today, and look forward to your statement.
Well, thank you, Congressman. It's nice to be here with the Ways and Means Committee, and I wanted to thank the Chairman and Ranking Member and members of the committee for the opportunity to discuss the President's 2013 budget for the Department of Health and Human Services. Our budget helps create an American economy that's built to last by strengthening the nation's health care, supporting research that will lead to tomorrow's treatments and cures, promoting opportunity for America's children and families, so everyone has a fair shot to reach his or her full potential. It makes investments that we need right now to keep our economy growing in the right direction, while reducing the deficit in the long term, to make sure that the programs that millions of Americans rely on will be there for generations to come. I look forward to answering your questions, but first I want to share some of the budget highlights. Over the last 2 years, we have been working diligently to deliver the benefits of the Affordable Care Act to the American people. Thanks to the law now in place, we have 2.5 million young Americans who have health coverage today, thanks to getting coverage through their parents' plans. More than 25 million of our senior citizens have taken advantage of free recommended preventive services under Medicare. Small business owners are taking advantage of the tax breaks on their health care bills that allow them to keep their health insurance and hire more employees. This year, we want to build on the important efforts by continuing to support states as they work to establish affordable insurance exchanges by 2014. Once these competitive marketplaces are in place, they'll ensure that all Americans, finally, have access to quality, affordable health coverage. Because we know that the lack of insurance is not the only obstacle to care, our budget also invests in the health care workforce. The budget supports training more than 7,100 primary care providers and placing them in parts of the country where they're needed the most. We're investing in expanding America's network of community health centers. Together with our 2012 resources, our budget creates more than 240 new access points for patient care, along with thousands of new jobs. Altogether, the health centers will provide access to quality care for 21 million additional Americans, 21 million people, 300,000 more than last year. This budget also continues our administration's commitment to improving the quality and safety of care by spending healthcare dollars more wisely. It means increasing our investments in health information technology and improving care for those who rely on both Medicare and Medicaid. It also means funding the first of its kind CMS Innovation Center, our own R&D support center, which is supporting and partnering with physicians, nurses, hospitals, private payers, and others who've accepted the challenge to develop a new sustainable healthcare system. In addition, our budget ensures that 21st century America will continue to lead the world in biomedical research by maintaining funding at the world's leading researchers at the National Institutes of Health, and will support their work with an emphasis on outcomes research that compares the risks, benefits, and effectiveness of medical breakthroughs so we can get the biggest payoff possible for our research dollars. The administration recognizes that in order for the country to succeed, we need to invest in tomorrow's scientists, as well as tomorrow's teachers, engineers, doctors, and architects. But today, too many young children have their futures shortchanged because they start school behind and never catch up. We know that high-quality early education programs put kids on a path to school success and to lifetimes of opportunity. High-quality early education doesn't just lead to higher test scores and graduation rates. We know it leads to more productive adults, stronger families, and more secure communities. And that's why our budget increases funding to support the 962,000 children in Head Start and the 1.5 million American children in federally funded child care assistance programs. Our investments also support critical reforms in both Head Start and child care programs to raise the bar on quality. This year, for the first time, we'll require Head Start programs that don't meet important quality benchmarks to compete for funding. Our budget supports a new child care quality initiative that allows states to invest directly in programs and teachers so that individual child care programs do a better job of meeting the needs of children and of their families. Investing in healthcare, cutting-edge medical research, early childhood education, and other priorities that help us create an American economy built to last requires resources. That means we have to set priorities, make difficult trade-offs, and ensure we use every dollar wisely. Our budget does this, helping reduce the deficit even while we invest in areas critical to our nation's future. That starts with a continuing support for President Obama's historic push to stamp out waste, fraud, and abuse in our healthcare system. Over the last 3 years, every dollar we've put into healthcare fraud and abuse control has returned more than $7. Last year alone, these efforts recovered more than $4 billion. And our budget builds on those efforts by giving law enforcement the technology and data to spot perpetrators early and prevent payments based on fraud from going out in the first place. The budget reflects the careful review we gave every program, looking for opportunities that make them leaner and more effective. And it includes some difficult cuts we wouldn't have made if our nation's fiscal health and tight budget times didn't require them. Our budget also contains more than $360 billion in healthcare savings over 10 years, most of which comes from reforms to Medicare and Medicaid. These are significant, but they are carefully crafted to protect beneficiaries. For example, we propose significant savings in Medicare by reducing drug costs, a plan that both lowers the overall cost of Medicare and puts money back in the pockets of Medicare beneficiaries. Our budget makes smart investments where they'll have the greatest impact. It ensures millions of Americans will have access to the health care they need, funds cutting-edge biomedical research, and invests in our youngest children so they can achieve their fullest potential. And it puts us all on a path to build a stronger, healthier, and more prosperous America for the future. Thank you again for the opportunity to be here today, and I look forward to our conversation.
Thank you, Secretary Sebelius. I was surprised that you failed to even mention the need to reform the Medicare physician payment formula in your 8-page written statement. Even more troubling is that the President Obama continues to recommend that the SGR be dealt with by expanding the deficit and debt. The President's budget proposes to spend $429 billion to fix the SGR without suggesting any offsets. A deficit-financed SGR package failed the Democrat-controlled Senate a couple years ago, and it certainly wouldn't pass this House. Instead of doing something to protect seniors' access to their doctors, the administration chose to cut Medicare by more than $1.5 trillion to fund a new entitlement that our country cannot afford. As a result, reforming the SGR has become exponentially more difficult, and doctors in my Northern California district and across the country are wondering if they will ever get more long-time certainty about their payments. The administration has yet to offer a single serious suggestion as to how to reform Medicare for physician payments. Is this truly a priority for the administration?
Well, Mr. Herger, I think that the President from the outset of this administration has recommended a long-term fix for the SGR proposal. In each of the last several HHS budgets, we've recommended specific offsets for those proposals, some 2, some 4 years. The President's 10-year budget includes a 10-year fix to the SGR proposal, unlike the month-to-month, week-to-week, day-to-day operations that we've been seeing. And I couldn't agree more that a long-term fix is required. As you know, the President's budget, taken as a whole, indeed does propose not only to fix the SGR, but to lower the deficit. So we feel that we are eager to work with Congress on a long-term fix. We are eager to look at this situation. I would suggest it isn't an HHS fix, it is a budget fix that is required for the 48 million Americans who currently rely on Medicare and more coming in every day. Nothing could be more important than ensuring that they'll have their health care providers, and we are eager to work with you to make sure that happens. But our budget does contain an SGR fix not only now but into the next 10 years.
The Medicare savings in the budgets, President's budget totals $302.8 billion, but the estimated cost for the SGR fix is $429 billion. Taken together, that means the President is proposing to increase Medicare spending by nearly $130 billion over the next 10 years. Isn't that just making the entitlement crisis even worse?
Again, Mr. Herger, I think the President's budget anticipates a long-term Medicare fix, not entirely made up from within the Department of Health and Human Services. He feels that making sure that Medicare beneficiaries have access to doctors is something that has been failed to be dealt with by Congress for years. The gap keeps growing year in and year out. We have proposed a variety of strategies, but his budget as a whole does have a 10-year fix built into the budget, as well as deficit reduction overall recommended. And we do have some of those proposals within our budget, but the President's budget as a whole does recommend a long-term fix and no deficit additional spending for this matter.
And I might say that the Republicans look forward to working with you and the administration.
That would be great.
This. Thank you. The ranking member, Mr. Levin, is recognized for 5 minutes.
Well, welcome again. And fortunately, your testimony was given to us in advance, so those of us who went to vote and missed your testimony had a chance to read it. So let me just ask you, I tried to touch on it in my opening remarks about how it's going. So how would you sum up how health reform is going, what it's meant so far? You live with it every day, if not every minute. So just give us your very personal view as to what's happening?
Well, Congressman, I have the opportunity to visit around the country, not only healthcare providers and some of the best medical systems in the world who are eagerly implementing strategies around care improvements and quality improvements, but also to talk to individuals who have already benefited from some of the early aspects of the healthcare law. I was with a group of women the other day in Baltimore. There was a mother of a child born with a pre-existing health condition who now knows that her child has insurance coverage not only now but into the future. We had a young recent college graduate who is trying to decide whether to go to law school or to work in a social service project who has insurance on her parents' health plan, one of 2.5 million Americans who's already taken advantage of that. We had 2 new National Health Service Corps providers with us in that room, 2 young doctors who wanted to practice in their community, were afraid that the debts they were acquiring as a result of medical school would be too significant to look at community service, and the National Health Service Corps is helping them pay those scholarship loans so they can indeed turn around and serve their communities. We know that efforts are underway in the Medicare system that millions of seniors have already taken advantage of accessing at least one of the new preventive services that no longer have copays, like mammograms and colon cancer checkups, have taken advantage of the new wellness visit, which is now a yearly annual visit. And we have millions of Americans that have now, instead of trying to make their prescription payments out of pocket because they reached the donut hole, had some almost $4 billion worth of relief because of closing of the donut hole in the health care plan. So I talk to people each and every day who are already seeing the benefits. There are a lot of people who are eager for the new insurance markets to exist, who are paying higher and higher rates, who see their policies not covering the needs for their families, who are locked out or priced out of the market. So we are seeing new benefits take hold and folks eager for 2014 to arrive and have a reset of the insurance marketplace.
And as to the exchanges, you want to just briefly give us a report on that?
Well, we are working actively with states around the country to implement state-based health insurance exchanges, and I would say that we have virtually every state in the country who has taken a planning grant. We have about 28 who are in the process of working on implementation grants. We have states who have strengthened their insurance oversight, which is critical right now to make sure that they actually are reviewing year-to-year rate increases. And I know as a former insurance commissioner, some states had the resources to do that, and a lot did not. We are working on IT programs and outreach programs, and we see governors doing everything from issuing executive orders to helping to pass legislation, Republicans and Democrats, who feel that a state-based exchange is the preferable way to go. And for those states who don't choose to build an exchange on their own, in their own area, we are putting together the framework to make sure that every American has an access to the benefits of an exchange marketplace beginning in 2014.
Thank you.
Well, thank you, Madam Secretary. In order to put the President's budget into context, I compared it to what he had proposed spending last year, and with regard to the health insurance exchange subsidy in using the same time period, 2011 through 2016, this year's proposal predicts a $33 billion increase, almost a third more will be spent on subsidies than what was anticipated and predicted last year over the exact same budget period. And this is just in the exchanges. So this, to me, means either one of two things. Either health insurance premiums in the exchange are going to be more expensive than first predicted, or more employers will drop health care coverage, forcing more people into the government-run exchanges, or a combination of those two. And I would just ask your opinion, which of those do you think that is?
I have to confess, Chairman Camp, I don't know all the underlying assumptions that those numbers are based on. We are clearly watching very closely what's happening in the marketplace. I don't think there's any question that as rates continue to go up, there is employers making a moment-by-moment decision. We are also informed by what has happened in the one fully fledged operational exchange in the state of Massachusetts, which preceded the Affordable Care Act, where employers not only did not drop coverage, but additional employers came into the marketplace. And I think that gives us a real live example of what happens when you have affordable, available coverage with some competition in the market.
But a more than 30% increase in the budgeted spending on health insurance exchanges is a significant departure from last year's prediction. And I would just wonder what would cause a $33 billion increase. It's either got to be that the exchanges are going to be more expensive, or more employers are going to drop coverage, and therefore more people will be in the exchanges, and therefore they're more expensive. So
Chairman
I'm
Camp,
trying to understand.
what is the $33 billion increase
That is
that you're referring to?
when looking at last year's budget over the same time period, 2011 to 2016, this year's budget, using the same time period, just in the exchanges, is saying that there will be $33 billion more spent over that 10-year period, over that period, in the exchanges in that 5-year period than last year. So my question to you is, why is it going up by a third? Why is there a $33 billion increase? And my estimate is it's either the exchange subsidies are much more expensive, and or employers are dropping coverage and more people are going in.
Well,
I just wondered your opinion on that.
Nothing has changed, excuse me, I'm sorry, nothing has changed in terms of the exchange subsidy rates that was built into the law when this bill was passed almost 2 years ago. I would be delighted to go back and get you a very specific answer, but frankly, I'm still a little baffled. It could be that the budget window has moved a year. I really don't know exactly.
The budget window did not move. The budget window
Well, I
stayed
mean,
the
we're
same.
in a different year.
Yeah, but
So the budget window for 5 years is out a year further, and I don't know the $33 billion that you're referring to, and I'd be glad to try and get you.
last year's budget window was also 2011 through 2016. But if maybe
Okay.
you could respond in writing,
I
I'd
will
appreciate
do that very quickly. I just can't answer that question right at
Um,
this moment.
Also, in your statement, which I did have a chance to read, thank you for getting it to us early, and I apologize for the vote, not being able to hear your oral testimony. But with regard to entitlement reform, under the section of your statement headed Living Within Our Means, the budget proposes to spend $126 billion more on Medicare over the next decade than would otherwise occur under current law. And the President has said that Medicare reforms are needed to put our nation on stable financial footing, but your statement really doesn't address Medicare reform or any direction or specifics on how we can protect and preserve Medicare. Can you tell me what is the plan to make sure that Medicare is here for today's and tomorrow's seniors? As we all know, it's going to go broke in the next 10 to 15 years. That doesn't really change under this budget. What is being done to help seniors to make sure that Medicare is there for them?
Well, actually, Chairman Camp, the passage of the Affordable Care Act, according to CBO and various other analyses, added about 12 years to the life of the Medicare Trust Fund. The President's budget adds an additional 2 years with some additional proposed savings, and we would be the first to acknowledge that that is not the next generation and beyond. We are eager to engage in a comprehensive conversation about the future of not only Medicare, but a variety of entitlement programs while we protect beneficiaries. I think what we can tell you pretty definitively is that the proposal put forward by and passed by the House Republicans that actually shifted costs to the backs of Medicare beneficiaries and whether they be seniors or disabled folks with no real underlying health care cost transformation is not something that is able to be supported by this administration. The voucher program that would essentially end Medicare as we know it, shift costs onto seniors, and yet no underlying health reforms.
I don't see any plan in this budget for the long-term sustainability of Medicare. I'll give you it extends Medicare's life by 2 years, but I don't think that really gives much comfort to seniors who are looking for a long-term, or those who are at or near retirement who are looking for the solvency of Medicare over the next 30 or 40 years. And I will say that sustainability for 2 years comes largely at the cost of provider cuts in Part A, which how sustainable those will be over the long term, we only can tell. But I don't see any real reform to Medicare here. I appreciate the talking points with regard to our budget, but at least we had a plan that really addressed the long-term solvency of the program. And
Mr. Chairman,
Medicare is still going broke in the next 10 to 15 years, and I don't see anything in this budget that specifically addresses that. I see money spent on a doc fix and provider cuts.
Mr. Chairman, I would suggest that in the Affordable Care Act, for the first time, are the real tools not only to, I think, have an opportunity to look at a sustainable Medicare program long-term and a sustainable Medicaid program long-term, but really more importantly, or as importantly, to address underlying healthcare costs which affect the private sector. What we don't want to do is just keep shifting dollars onto either payment onto the backs of beneficiaries or private payers. We have to actually get a handle on the overall healthcare costs, and I think some of the strategies in the Affordable Care Act to use for the first time the public payment system as an innovative strategy, moving us to a value-based payment system, moving away from a volume-based system, is not only going to be enormously cost-effective and patient-effective in Medicare and Medicaid, but can be enormously helpful for the private sector, which is why they've enthusiastically embraced a lot of the new innovative strategies that are beginning to be realized.
All right, thank you. Mr. Stark may inquire.
Thank you, Mr. Chairman. Madam Secretary, thank you, as always, for your work in these fields. If we were to replace traditional Medicare with a voucher or some kind of fixed payment plan, as my colleagues on the other side voted for in the Ryan budget, what, in your position, would you suggest that, what would be the effect of that on Medicare beneficiaries? It's probably a selfish question in my regard, but for my kids, if you throw them into the private insurance market with a voucher that arguably wouldn't pay today's rates, what happens?
Well, I don't think there's much question, at least the analysis done on the original proposals are that there's a very substantial cost shift onto beneficiaries and no real indication that overall costs would go down. It isn't that we're saving money. The government is saving money, but health care costs continue to rise, and one could speculate, given the fact that Medicare Advantage has been in place for years and was allegedly going to lower costs through competition with the fee-for-service plan, and that really has not proven to be an effective strategy, that costs would rise even more significantly than they are now. The government would owe less. There's no question about it. The government would shift the costs of providing health care from a government beneficiary ratio where it is today much more heavily onto beneficiaries. So seniors would pay more, disabled people would pay more overall on their health care costs.
Could we speculate for a minute on the doomsday, the worst case scenario, whatever you want to call it? And whenever people want to project that Medicare is going to go broke. I can't speak to Medicaid. We have to leave that to our sister committee. But in the case of Medicare, it would be my understanding that the maximum that we would have to increase the payments from employers and employees to keep Medicare solvent for the indefinable future would be about 0.5%, a quarter on the employees and a quarter on the employers. Not an insignificant amount, but if that were the maximum, as I'm led to believe, it hardly sounds like doomsday to me. Am I about right, in the right ballpark on that 0.5%?
I think, Mr. Stark, that is my understanding. If you just froze things in place, I think what is really incumbent upon all of us, and I would eagerly work with members of Congress to look at this scenario, is looking at our overall health spending, not Medicare in isolation or Medicaid in isolation, but those are, frankly, two of the largest insurance programs in the world. But what we're doing in terms of just overall health costs, where we're spending significantly more than any nation on earth, and yet we have fairly mediocre health results. That's, to me, the underlying challenge that we have. And within solving that challenge, how we eliminate duplication, go after waste and fraud, figure out strategies that actually intervene at a much earlier stage with preventive care and wellness care, go to the underlying causes of 75% of our deaths here in America, which are smoking and obesity. If we can actually address that, it will lower costs overall and produce a healthier country.
Thank you very much. Thank you, Mr. Chairman.
Thank you. Mr. Johnson's recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you, Madam. The Democrat health care law provided $1 billion to implement the health care overhaul. Now the President's requesting another $1 billion for implementation of the same law. I don't understand how HHS can blow through this kind of money when many of the provisions it's supposed to implement don't even take effect till 2014. Your testimony has a section you refer to as living within our means. How can you say that HHS is committed to deficit reduction and living within your means when you're continuing to make requests like this? It's just another example of how the administration drastically underreported the cost of the health care law. Can you tell us exactly where the money's going and how much more you think you're going to need before we get to the point where it really takes effect? Clearly, those first numbers were off.
Well, actually, Mr. Johnson, they were off, and the good news is we are underspending what was estimated. The original estimations for implementation of the Health Care Act, and that was part of the public testimony and actually would have been in some reconciliation legislation but was not able to be considered, was about $1 billion a year. We have to date, as of December of this year, obligated about $475 million of the original $1 billion. So we are spending, after 2 years, significantly below what the estimate was.
But you're asking for another billion.
I'd love to finish this. So what we have coming up in the remainder of 2012, and again, out of that 475, about 260 of it is HHS spending. The rest is with our companion agencies. We anticipate that during the remainder of FY 2012, the first $1 billion will be spent. That will be about 2.5 years into implementation, significantly, again, below the $1 billion a year that was estimated. But in 2013, we are requesting about $800 million to come into the overall implementation of health reform to build one-time build-out for the framework of a federally operated exchange, which is part of the law that will go into everything from education and outreach to building the IT system to setting up the technology. and the remainder of that $1 billion request to the Centers for Medicare and Medicaid Services, Mr. Johnson, is directed toward Medicare and Medicaid activities, not to the exchanges.
Yeah, but you had $1 billion to start with for setting all that up, and you're asking for another $1 billion this year. And I don't think you really adequately answered that, but let me ask you another question. Medicare actuaries and CBO have warned it is unclear if current Medicare cuts can be sustained or if they will instead reduce access to care or lower the quality of care for Medicare beneficiaries. I hear from back home in all areas of health care, doctors, hospitals, rehabs, who say they are seriously considering not accepting Medicare or will have to close because of reimbursement issues and burdensome regulations. Are you going to put steps in place so you can identify access problems before they become a crisis? And how are you going to keep seniors from being denied access?
Congressman, I think that there's no higher priority within not only this administration, but certainly within CMS to make sure that beneficiaries are getting the health care that they need and that they deserve. And so we have a very active monitoring process. I would say the most significant looming challenge, and the chairman and I discussed this a bit, is the not long-term addressing of the doctor payment in Medicare. The reason that providers are getting very frustrated is that we have not indeed found a long-term solution, making sure that providers know that if they engage in the Medicare system, they will be paid month to month, year to year. But we are watching that very closely. As I say, the President's budget includes a 10-year fix to the SGR program. We would love to engage with you in Congress and have a multi-year fix. That has not happened. As you know, we've come right up to the precipice and last year had to actually suspend payments for a period of time to get a fix done. So we're eager to look at reimbursement to providers being the most essential I think, component of making sure that there is some certainty to deliver the benefits.
Docs are an important part of our society. Thank you, Mr. Chairman.
Thank you. Mr. Brady's recognized for 5 minutes.
Thank you, Mr. Chairman. There's no question. I think now a year later, we can tell under the President's health care plan, costs are exploding for Obamacare. Prices are up for families and businesses. Many businesses are preparing to drop their private coverage and move their workers into the exchanges at cost to taxpayers. And many other businesses are working hard to stay under the 50 employee limit. One thing that worries me is how we will treat the seniors who today are on and rely upon Medicare Advantage, a hugely popular program in my state and others. I saw on a recent White House blog that one of the staff, Nancy Ann DePearl, stated that the $200 billion in cuts to Medicare Advantage programs that was predicted to disrupt seniors' access to health care, quote, turned out to be wrong. But can you tell me what percentage of the cuts to Medicare Advantage called for under the President's health care law? How many have been implemented so far?
Well, Mr. Brady, what is not going to happen is a cut to Medicare Advantage. What is going to happen is a gradual reduction in the overpayment to Medicare Advantage, which we're being paid at about 12 to 14% more than traditional fee-to-service
So those
Medicare with
reimbursements
no
will be
additional.
cut by, according to CBO, those reimbursements will be cut for Medicare Advantage. And your actuary said that the impact would be over 7 million American seniors would lose coverage, and almost 50% of seniors would no longer be enrolling in Medicare Advantage. Is your actuary
we've seen
correct?
just the opposite. Enrollment has increased.
Well, now wait a
10%.
minute.
We've
Madam
got
Secretary,
11
if I
million
may,
more people,
when you
and
say
costs
it's
are
just
going
the
down.
opposite, isn't it true only 4% of the cuts contained in the law have been implemented, and you backfilled it recently with $6 billion of grants to these same Medicare Advantage providers? So how can you truthfully say that there hasn't been an impact when, in fact, these cuts have been delayed, I think, probably for election year gain. So how can you say that there has been no impact when the cuts haven't occurred?
Well, as you just said yourself, cuts have been, the reduction in overpayment has begun.
But they've been
We are-
delayed, correct?
No, that is not true, sir. The average plan premiums are down last year
No, I'm
and again
sorry.
this year.
I may
The
be
bids are
confusing the
down for the
Medicare
company.
premiums, and I'm asking you about the cuts within the law.
Well, we are
You're saying-
reducing the payments to companies, not to providers. We are, by law, reducing the payments, and that actually has begun to be a very successful strategy. At the same time, for
But
the
would you
first
admit,
time ever.
I don't mean, I'm just trying to get the truth here. Are you saying, will you agree that according to your actuaries, only 4% of the cuts have taken place?
I assume if that's accurate.
And you've backfilled that with over $6 billion of grants to them. So when you talk
Sir, we
about
have
the
put in place
impact,
for the first time ever a quality program so that higher performing Medicare Advantage plans, so the first time, are actually receiving a quality bonus. The lower performing plans are not.
So-
And beneficiaries finally have a place to make a
so there are no real
determination.
cuts.
No,
You
that is not
backfilled it.
true. Sir, that's just not true.
Well, you started your testimony, your answer to
4%.
me saying there's been no cuts to Medicare Advantage.
4% is what the actuary quoted. I'm agreeing with your numbers. And we are now in year 2 of strategy. What we're seeing is more plans, lower prices for beneficiaries, better quality. I think that's kind of a win-win
But-
situation.
And you'll say that, and you're saying that will continue because the $206 billion in cuts will occur in the future?
Yes, sir.
And that
I
will-
think it absolutely, we're seeing more companies. The companies are well aware of what the framework of the law is.
Now, let me
We
just
are
say,
not saying-
your own people are saying those cuts will push 7 million American seniors off Medicare Advantage, cutting nearly half of them out of enrollment.
Sir, and
So
all
when you
due
say-
deference to actuaries, they're not running the companies.
Well,
What
these aren't
we're-
my actuaries, those are yours.
But we're seeing the companies, the insurance companies running Medicare Advantage programs coming into the market. More plans are
Because the
available to,
cuts haven't occurred, wouldn't you agree?
they know
and you're
exactly what
giving
the
them
framework is.
grants
I do not
To
agree.
stay in the
clearly.
marketplace. Mr. Chairman, I will.
Time has expired.
Thank
Mr. McDermott's recognized.
Thank you, Mr. Chairman. Secretary Sebelius, I can't think the president could have picked a better person to be the Health and Human Services Secretary, given your insurance background and your governor's background. And I know that you've managed these programs out at the state level, and as I listen to this debate about whether there are cuts or not, let me clarify something. Does Medicare guarantee that doctors can submit their usual and customary fees?
Yes.
So they get to set the price. And then you pay how much of that? 70%, 60%, whatever? How do you decide that? Because I hear doctors sound like farmers to me, and I'm a doctor, so I could say that. They sound like farmers. There's never a good year. They always, oh, this is the year we had too much rain, or we had too much sun, or we had too much something. And doctors always say they're underpaid, but they're submitting amounts that you don't pay. And that is your stewardship of the federal purse. Isn't it correct?
Well, the payment schedule, as you know, Mr. McDermott, is determined a year at a time with a global look to provider fees, and it's well known to providers, which is why I think we have, 99 or 99.6% of all medical providers participating in the Medicare program.
So we're actually listening to 0.4% bellyache about the fact they didn't get every dime they billed.
I think what is true, and I am very sympathetic to this and also eager to work on a long-term strategy, is looming a 30% budget cut with the sustainable growth rate not fixed, and have that come up year in and year out, month in and month out, provides a level of serious instability to the program long term. And I think that is something that we must fix, that the President is eager to work on. His budget includes it, but that's the instability of Medicare, not, I don't think, the other payment issues.
That was built in to the Medicare system by Chairman Thomas of this committee in 1997 in the budget, the Balanced Budget Act.
And it worked for a number of years because it was supposed to rise and fall, but I would suggest over the last decade it has been
Exactly.
not so
So
terrific.
built into the Accountable Care Act was an attempt to develop a new payment system for doctors, not based on volume.
correct.
And I see this press release that just came out of the largest Medicare fraud in Dallas, Texas. $375 million to one doctor. Now, I ask myself, how did he get away with that for 5 years? And was it revealed because somebody blew the whistle on him, or was it because your format of looking at the bills found this guy who's down there, and he was doing it on the basis of volume? He collected the largest number of Medicare beneficiaries in history, in the entire country. This guy was building up his money by putting through volume. That's what it looks like to me. And that's why the efforts in the Accountable Care Act to get to a new payment system really make sense to me.
Well, I think all of the above is true. What the congressman is referring to is that today in Texas, a single health care provider was arrested and has been billing 78 Texas home health agencies fraudulently, and we think the amount is somewhere around $375 million. It could be well more. I think it is part of the effort that is really underway with the HEAT task force, which includes not only Department of Health and Human Services personnel, but Justice Department, U.S. attorneys, and investigators on the ground to really target where we think the fraud hotspots are, and building the predictive modeling, which looks at billing errancies. In the past, you really couldn't do that very easily because there were 6 different billing systems, so you couldn't even look at data real time. This is, I think, an indication that we're beginning to at least turn some of the corners, and we intend to be very serious about it. But you're absolutely right. In the long run, paying doctors differently is part of the overall reform strategy. And again, not only affects Medicare programs, but will affect private payers. Paying on volume, the number of tests you do, the number of days someone spends in a hospital, the number of things done, as opposed to quality outcomes, preventive interventions, more timely access, and a patient-centered care system, I think, is where we need to go in this country as rapidly as possible. But in the short term, we need a strategy that assures doctors, if they're taking 48 million Medicare beneficiaries and treating them, we need to make sure that the government is a good payment partner and they don't have to worry month to month, week to week about whether they're going to get paid.
All right, thank you.
Thank you.
Time has expired. Chairman Ryan's recognized for 5 minutes.
Thank you. Madam Secretary, today we had Rick Foster, your chief actuary at CMS, in Budget Committee this morning to testify, along with Steve Goss from Social Security. And he went into great length to discuss sort of the virtue of a premium support-like model and how having bid-based pricing, competitive bidding can help to actually reduce cost growth, to help stretch that healthcare dollar further, and to get the best benefit at the lowest possible price. And so I would just encourage you to listen to some of the testimony he's offered and some of the wisdom he's given and some of the lessons we've learned through various things like Part D and DME and other issues where we've been able to, through bid-based pricing and competitive bidding, stretch our healthcare dollar further. I want to ask you about your latest budget proposal. This is page 55 of your budget, where you talk about strengthening IPAB to reduce long-term care drivers of Medicare cost growth. You take the the cap from GDP plus 1 to GDP 0.5, and obviously that achieves savings. But some of the tools available, it talks about offering new tools to IPAB, including the consideration of value-based benefit design. What does that mean?
What does value-based benefit
Yeah.
design mean? I think it means that you look at outcome strategies, which are part of what is part of our direction in the Affordable Care Act. So we're implementing, for instance, through the Innovation Center, everything from bundled payment strategies to see if that actually lowers hospital readmissions, to make sure that doctors and follow-up placements are coordinating. We're looking at medical home models to look at chronically ill and whether care delivery could be more effective and prevent readmissions in the first place. We're looking at patient partnership to look at hospital-acquired infections. So all of those are value-based payment strategies.
Right, so does it mean changing the benefit design to get better value?
It isn't changing necessarily the benefit design, it's changing the way that the delivery system works.
So does that mean that the IPAB is given this tool for them to decide how that is to be interpreted? The point I'm trying to make is, in one sentence, the budget and the Affordable Care Act says IPAB can't change beneficiaries' benefit designs.
That's correct.
And in another sentence, it says IPAB should be given this tool to implement value-based benefit designs. It seems to me that there's a contradiction here, and I'm trying to understand how that occurs and how IPAB will come down on that. It strikes me that IPAB is given this discretion to interpret what that means, and that could clearly collide with beneficiary design. That's question one. How is that not a contradiction? That's the question. Question two is, what's the status of IPAB? I understand you're supposed to select the board this year, and they're supposed to be up and running next year, and then I think implementing recommendations by 2014, if I'm not mistaken. Can you give me a status update on that?
Sure, but let me take the first question about, as you know, Chairman Ryan, the IPAB statutory framework is that they are prohibited as an entity from doing certain things, from shifting costs onto beneficiaries, from changing the benefit package. So there are a series of prohibitions that control what IPAB's recommendations need to be as they look at a more efficient, effective way to deliver health care. Also, IPAB doesn't do anything, implement anything. They make recommendations to Congress. If the targeted spending is above what the IPAB target is, they are charged with making recommendations to Congress about how to make up that difference.
If Congress doesn't act, do their recommendations go into place?
If Congress does not act, if Congress fails to act on the recommendations or substitute those recommendations, I am directed to implement the IPAB recommendations. But Congress is the intervening body receiving the recommendations.
Is the required threshold more than a majority vote for Congress's action?
Is it a supermajority?
The answer is yes. I could answer it for you if you want. Here's the point I'm trying to make, Madam Secretary.
Congress clearly can act, though the recommendations come to Congress. IPAB does not have the authority to implement anything on its own. In terms of the status of IPAB, at this point, as you know, again, the statute entails having members who would be nominated by a series of both legislative leaders and the President, confirmed by the United States Senate. There are active discussions underway about those possible candidates. Vetting those folks are not an easy task because this must be a full-time job. They cannot have any conflicts with any of the possible payment sources, and so that discussion is underway.
What's your general timeline?
I really don't know, Chairman, because IPAB is not likely to even be operational into 2018 or 2019, given the cost trends. So
You're
I
supposed
would
to be
say
making recommendations in 2014, correct?
All right, time has expired. Mr. Teaberry is recognized for 5 minutes.
Thank you, Madam Secretary. Welcome to our committee. Thank you for being here. 3 points and then a question. First point is, I had a constituent who met with CMS late last year over a program that he believes will save, and he has documentation on this, $200 million a year to CMS and also save beneficiaries. He was kind of laughed out of the building, he said, because that wasn't very much money. We sent a follow-up letter to CMS and have been given kind of the brush off. I would like to send you a letter. And
I'd
have your
appreciate
staff
that.
look into it. Thank you very, very much.
$200 million is real money.
I agree. Second issue is, you and I had a discussion last year when you were here about my godmother who just lost her physician because he began not accepting not only new Medicare patients, but getting rid of former Medicare patients. And just a week ago, I received a letter, a copied letter that was actually sent to your boss, the President of the United States, and I spoke to this doctor who I've never met before or talked to before. Her name is Deborah Moritz, and I'd like to read you part of it. It says, Dear Mr. President, I can no longer afford to take new Medicare patients. I've seen a lot of inadequate management of Medicare patients, including my own parents. We can no longer afford to spend the time it takes to address multiple problems Medicare patients face. Rather than trying to accept that inadequate time or cost, I have decided to decline seeing new patients. I just can't afford to treat them. A free market, even if only for 3 to 5 years, would eventually level out the cost so that the true cost could be assessed. I'm not even going to address the burnout all of these issues create. All my colleagues express concern that we as doctors won't even be able to get medical care when we retire because all the good doctors are burning out and quitting. Mr. Chairman, I'd like to submit this letter for the record along with a attachment that she included from a medical journal entitled Government Medicine is Hazardous to Your Health. Again, I think it's a problem. You don't need to comment on it.
Without objection.
Thank you, Mr. Chairman. I think it's a problem that continues to occur throughout our nation. Final issue that I'd like to see if you would answer a question on. The Bishop of Columbus, Bishop Frederick Campbell, put out a letter a couple weeks ago after the ruling that you'd put out. And I'd like to read part of it. This was sent out to his constituency within the Columbus Diocese, which also includes, according to Bishop Campbell, a number of schools and a number of charities. And I quote from his letter regarding the HHS's recent ruling. In so ruling, the administration has cast aside the First Amendment to the Constitution of the United States, denying to Catholics our nation's first and most fundamental freedom, that of religious liberty. And as a result, unless the rule is overturned, we Catholics will be compelled either to violate our consciences or to drop health care coverage for our employees and suffer the penalties for doing so. The administration's sole concession was to give our institutions 1 year to comply. We will not comply with this unjust law. And talking to Bishop Campbell, he believes the so-called accommodation recently issued by the President does nothing to remedy the problem, and that the regulation encroaches on the religious freedoms and the First Amendment. CRS just put out a report saying that if employers, for instance, had 100 employees, Madam Secretary, and refused to comply with the mandate, there would be a $100 a day fine for each individual employee. So you could add that up to $3.65 million for the year. The Diocese of Columbus has many more than just 100 employees, all of whom, when they got hired, knew what health care they were getting. And the bishop and I talked about the President so clearly saying, if you like what you have, you can keep it. He said that over and over many times. My question to you is, if they refuse the mandate, refuse to violate their First Amendment, refuse to violate their religious beliefs, and refuse to pay the fine, what consequences as an employer will Bishop Campbell face?
Congressman, I think what you're referring to is a portion of the Affordable Care Act where we were directed to develop a set of preventive health measures specifically for women's health, which has been a missing piece of a lot of insurance puzzles for a long time. We turned to the independent doctors and researchers at the Institute of Medicine who came back with 8 recommendations, well woman screening and domestic violence screening and contraceptive coverage and mental health services, which are often missing from parts of the plan. We then looked around the country at the 28 states which have mandatory contraception laws already in place, many of which existed from the mid-90s, and looked at the way those laws are enacted, particularly with regard to religious freedom and religious facilities, and proposed in the rule the exemption that was the most commonly used among states who had any kind of exemption. That rule was finalized at the end of January, and it fully exempts churches and church affiliates. We think it also applies to likely most parochial schools, many religious high schools. Those employers who are not fully exempt in the declaration in January would be given a year to comply, and we pledge to work with religious leaders around their religious objections. In February, I joined the President in announcing that we will be promulgating a rule which will, I think, both not only ensure religious liberty, but also women's health benefits. And it mandates that insurance companies, not the providers, but insurance companies will be making available to women
They're
at their
self-insured.
choice. We will have a provision dealing with self-insured plans who work through third-party administrators to make sure that anyone with a religious exemption will not provide or pay for or refer people to contraception services and maintain their religious freedom. On the other hand, we'll make sure that women across this country don't be, by the virtue of where she works or where her spouse works or where her parents work, have health benefits that are limited. So I think the accommodation made to religious providers, which doesn't come into effect for 18 months, is one that protects religious liberty, but makes sure that women's health services will be full and complete for the first time ever in the history of this country.
Time has expired, but I didn't hear what would be the penalty if
Thank you, Mr.
he
Chairman.
did not comply. To Mr. Teaberry's question, I know we're way over time here, but if you could.
I have no idea the hypothetical. I mean, I can, if you want to submit that in writing, I'll get you an answer in writing, but I don't have.
Thank you.
Mr. Lewis is recognized for 5 minutes.
Well, thank you very much, Mr. Chairman. Madam Secretary, thank you for being here today. Thank you for your vision. Thank you for your leadership. You know, Madam Secretary, I believe that health care is a right and not a privilege. And as we implement the Affordable Care Act, I know that we're moving closer and closer to that promise of health care for all Americans. I'm so proud of the success that you're having with the Affordable Care Act. Already, millions of young people with access to their parents' health insurance, millions of seniors with free preventive care and low costs on prescription drugs. And that's just the beginning. And I want to take just a moment to thank you for your commitment to women's health. That is important. No man, no state, no federal government should be able to tell a woman what she can or cannot do with her body. Madam Secretary, Republicans in Congress have made it their first priority to repeal the Affordable Care Act and put insurance companies back in charge. After all of the success we've had, I think this is just a bad idea. Can you tell us, tell members of this committee, what will happen to American families, consumers, and seniors if Republicans repeal health reform?
Well, Congressman, I think the benefits that you just recited with 2.5 million young Americans who now have coverage who were uninsured 2 years ago would go away. Clearly, seniors would lose the preventive care measures that now they can access without copays or coinsurance through Medicare. And we know that millions of seniors are doing just that. The 3.5 million, almost 4 million seniors who are watching their donut hole payments for prescription drugs be cut in half this year would again be in a situation where they'd have to choose between buying groceries or buying their medicine. We know that parents who have children with pre-existing health conditions would now then once again have the insurance companies lock them out of the marketplace. Cancer victims who now know that their benefits can't run out in the middle of a treatment would be back in the soup. And I think back to the discussion that I know is of great concern to this committee overall, there would be no opportunity to really look at the overall trajectory of health care costs. Insurance companies would pick and choose who gets covered. The health insurance market would continue to shrink, which it has been doing year in and year out as young and healthier people drop out because of the lack of competition and the lack of affordable coverage. So I think that short term it's bad news for millions of people who already have engaged with the benefits. Long term it's even worse news because there'd be no health care spending control and there would be very little opportunity for small business owners and individuals to ever have affordable health coverage.
Now, Madam Secretary, some people are suggesting that the Affordable Care Act would be bad for small business. Can you tell me or describe how this act help and assist small businesses?
Well, I don't think there's any question, and some of this is based on days in the insurance department in Kansas. Small business owners, family farmers, others are often at the shortest end of the stick in the insurance market. They don't have any market leverage because they don't have enough employees to negotiate for their own policy. And if there is a health incident of any family member or any employer, they actually pay significantly higher rates. And I think on average they're paying about 20% more than their large competitors are paying for exactly the same coverage. And year in and year out, those rates are skyrocketing, again, because often they don't have market power. So in the days where there will be a state-based insurance exchange, small business owners won't have to join an association or provide any membership fee or do anything else. They will have a new shopping marketplace where they will be part of a much larger virtual pool. Pre-existing conditions may not be considered. Companies will have to compete on the basis of price and product for the first time ever. And small business owners, I think, not only get tax credits now and into the future, but are potentially the biggest winners in the new marketplace.
Well, thank you very much, Madam
Thank you.
Secretary. Thank you, Mr. Chairman.
Thank you. Mr. Davis is recognized for 5 minutes.
Thank you, Mr. Chairman. I'd like to move away from health issues for a moment and talk about human services. From temporary assistance to needy families to child care and child support enforcement, I know we both share the view that the programs are important to families as they move to self-sufficiency. While they all have a similar goal of helping low-income families, for the most part, they operate independently. And notice there's a tremendous amount of program redundancy and also a lack of ability of systems to communicate. Before I came to the Congress, I ran a consulting firm focused on system integration and lean operations, in effect helping companies maximize effectiveness by minimizing complexity. In the private sector, a well-run business will coordinate information and resources between its operating divisions and saving a lot of money in the process and reducing overhead, being much more agile and being able to respond to customers. Unfortunately, many of our human services programs don't operate this way. I chair the Human Resources Subcommittee and deal with this on a weekly basis here in the Congress. And inside HHS, there are many legacy systems and processes that are siloed, many of which were actually put in place when you and I were children. As you know, the House has moved several bipartisan efforts to standardize the exchange of data and reporting in human service programs. The most recent example was in the recent Middle Class Tax Relief and Job Creation Act. We have referred to a provision inside of that as data standardization, and the chairman worked very hard to make sure that that got all the way through the conference committee. My view is that you can't fix what you can't measure, and data standardization will make reported and collected data more interactive and useful to better measure our outcomes and proactively identify problems and improve the effective use of taxpayer dollars. Our overarching long-term goal is to improve the efficiency and coordination of these programs in order to help more families become self-sufficient. And I think there's some common ground here. What I'm interested in hearing your thoughts on, or I'd like to hear your thoughts on data standardization in general, but several questions, or a question with several parts. First, do you agree that human service programs are siloed and could operate in a more efficient manner? Secondly, do you think that this data standardization provision will be helpful in better coordinating programs and services, and in fact should be expanded into other parts of your jurisdiction? And third, what more can Congress do to help your department bring these programs into the 21st century? And I'm focused very much on the processes. There will always be ideological or policy issues where we may disagree, but from a fundamental business perspective, I'd like to hear your views on this.
Well, Mr. Davis, my understanding is from our staff that this effort on data standardization was not only enormously productive and found a lot of common ground, but we are eager to continue to work with you and others on identifying other areas. I don't think there's any question that government programs are often siloed. We have done an effort across the Department of Health and Human Services to look at redundancies, try and eliminate areas where we're repeating mechanisms. We've gone to a data sharing platform in many systems where people are not any longer building new data systems to support some unique program, but looking at ways to share that. But we would be eager to find additional strategies, sometimes new eyes, and looks at budgets, reveal things that people haven't seen from the outset. And I'm a huge believer in the more efficiently we can operate any of our programs, the more strategies we can implement that not only have been in place in the private sector 10 years ago, but some of them 50 years ago are all good news. And so I would look forward to that. And again, I think the project that you mentioned, my understanding is off to a good start, but we would love to find additional ways to continue that.
I appreciate that. One thing that I would note, I know the gentleman from Washington State mentioned earlier about the recent fraud case in Dallas, Texas. When we look at improper payments, the wider aspect of this, about 10.5% of all payments coming out of the Center for Medicare and Medicaid Services fall into the category of improper. And I've stopped in my own committee jurisdiction, but just frankly, as an engineer by background, not looking at this in terms of that. But most of the challenges that I think we're facing are driven by broken processes in this area with payments. And I guess I would leave one final question, and we do look forward to working with you on this, is would you like to see this standardization effort extended into the healthcare jurisdiction for us to move that legislation, and would you help us move that data standardization legislation into the space with the Center for Medicare Services to address this issue?
Well, I'd certainly love to continue a conversation. I'm not quite sure what the global question implies, but I can tell you in the improper payment space, I just want to make it very clear to members of Congress that improper payment and fraud are two very different things, that there are healthcare providers who don't fill out a form accurately and it's sent back and they fill it out accurately. That's an improper payment. It's important to reduce those numbers, and we have had a program in place of lots of training and outreach. Some is fraud, and we're also building, I think for the first time ever, a central data system, a predictive modeling system, using some of the strategies that have been very effective in the private sector for decades, finally bringing them to this program. So again, I just would look forward to continuing the conversation and finding ways to make this more applicable across the board.
Thank you, Madam Secretary. Thank you, Mr. Chairman.
Thank you. Mr. Reichert's recognized for 5 minutes.
Thank you, Mr. Chairman. Well, welcome, Madam Secretary. Thank you for being here today. I think that all of us on this panel agree with you on a number of things that you have testified to today, and some of those I'd like to quickly repeat. Quality versus quantity. I think we can all agree that that's a goal. Efficient service, cost-effective service, accessible service, all of those things I think all of us who are trying to resolve this issue would agree that would be a great thing to accomplish. but we know it's going to take a while. I want to focus on the cost increase, and the chairman touched on this question, as did some others, and a promise that was made by the president. This was a promise that everyone could keep their health insurance if they liked it. If you like your health insurance, you can keep it. I think Mr. Teaberry mentioned that earlier. You and I had a conversation, I think, the last time you appeared here regarding this issue. But since that time, your own organization has said, so in your agency, regulation on grandfathered health plans stated that 7 out of 10 employers will not be able to maintain their grandfathered status. According to a survey completed last fall by Towers Watson, 1 out of every 10 mid-sized or big employers expect to stop offering health care coverage to workers after insurance exchanges begin in 2014. So that seems to run contrary, at least from my perspective, to the President's promise. And also connected with this issue is the 11.4 million Americans who have their own health savings accounts, who have great concerns as to whether or not they will be able to keep their health care plans because of the restrictions of the law placed upon health savings accounts. Can you commit today that the 11.4 million Americans with HSAs will be able to keep their plans in 2014 and beyond?
Congressman, as you know, that as part of the implementation strategy, we are looking at what will constitute health insurance, and some of those plans are very much companions to a health insurance plan and would very much be applicable on into the future. Others are not insurance plans. They're really kind of savings plans for portions of health care costs that are not covered by insurance, but they don't accompany a health care plan. So it's impossible to say across the board what will happen, as the part of the goal of the Affordable Care Act, as you know, is to have a health insurance plan which has a comprehensive set of benefits, but also has affordable characteristics. And your notion that somehow companies in grandfathered plans will not be able to keep their grandfathered plan is really not accurate. What that reflects is employers changing the plan on a voluntary basis in a marketplace where they are looking to new or innovative strategies or other operations, and so they have made the choice to change the insurance plan outside the grandfather rule. It's nothing that the Affordable Care Act is imposing on them. It's the employer or issuer's choice.
They make that decision based upon the language in the law, though?
No,
So
sir.
the
The language in the law basically defined what you have in 2010, and it put some framework around that snapshot. And if an employer in a voluntary market chooses to change that plan, he or she is well within their capability of doing that, and they're doing that all the time. And that's what the projection is.
If I may, Madam Secretary, the bottom line is if you like your health care plan, you're not going to be able to keep it. It's going to change. The last question I have is that thanks to Children's Hospital Graduate Medical Education Program, children's hospitals have not only expanded their residency programs, they've also increased their training experience and services in underserved communities, expanding children's access to care. Hospitals like Children's train over 5,600 full-time equivalent residents annually. The administration has proposed cutting this funding by 2/3. Have you looked into the impact of this cut on children's access to health care and how it will look in the future?
I have, Congressman, and I've actually visited with a lot of the leaders at children's hospitals across the country. There's no question that in a better budget time, I think a robust funding of all graduate medical education would be the preferred path forward. What this budget reflects is a redirection of some of those dollars to research universities and others who are focused primarily on additional primary care providers, and there are other sources of funding outside of the children's graduate medical education that funnel into children's hospitals. So we are watching very closely the good work they do and the access to care, and we'll continue to monitor that as we move forward.
Thank you, Mr. Chairman.
Thank you. Mr. Neal's recognized.
Thank you, Mr. Chairman, Madam Secretary. I don't think we should understate the progress that you've been making in the area of fraud. I think there are many more stories that dominate headline and evening newscasts. And during the run-up to the health care debate, I pushed the Democratic leadership really hard as an act of credibility to continue to weed out fraud wherever it can be found. It's still estimated, as you know, that there's up to $50 billion of fraud in Medicare. And is that number accurate as you see it?
I think, Mr. Neal, it's almost impossible. If we knew where it was, we'd go get it.
Sure. No,
So
understandable. My point is you're making progress.
It's
on
a substantial program, and we think there's probably way too much fraud involved in the operations.
But I think it should be acknowledged that the effort is now being made on a sustained basis.
Well, there's no question that the tools that were provided as part of the Affordable Care Act are the toughest anti-fraud legislation ever in the history of this country, doubling criminal penalties, giving us new civil sanctions, setting up resources so that for the first time on a department-to-department basis, the Justice Department and HHS are very much at the table, focused on hotspots, the ability to build a predictive modeling system, re-credentialing of providers in some of the most troubled areas, all of which is beginning to pay big dividends. The Attorney General and I were able to announce a couple of weeks ago that in calendar year 2011, the largest single year for recovering fraudulent efforts, $4 billion was returned to the trust fund. Medicaid funds were returned to Medicaid states across this country, and these efforts are really just beginning. We're 2 years in, but I don't think there's any question that for the first time there is a very serious, very focused, driven from the president on down effort to really target and not just prosecute after the fact, but prevent before the money goes out the door, and that's going to be a huge change.
And I think that needs to be acknowledged, and I'm pleased with the way you framed it. I do share Mr. Reichardt's concerns about children's hospitals. We have an exceptional one, as you know, in Boston, and they have petitioned me, obviously, to raise the issue with you, and I can't think of better advocacy than the role that they play every day. I mean, that's a jewel in the hospitals across Massachusetts, and I think that where we might be able to find additional money for them, it would be very helpful. And in addition, the rehabilitation hospitals, they're concerned that their funding has been flat now since I think about 2004. So I would urge there. I have a substantial rehab hospital as well. Of course, Massachusetts, you could find a hospital in many places, but it's very important to all of us, not just in terms of only first-class health care, but as a great economic engine for research across the New England region. Thank you, Mr. Chairman.
Thank you. Dr. Bistani is recognized.
Thank you, Mr. Chairman. Secretary Sebelius, in July of last year, you told the House Energy and Commerce Committee IPAB may not ration care, but you admitted that this word remains undefined in the 2010 law. And the health law only requires IPAB to protect seniors' access to the extent feasible when mandatory spending, when dealing with meeting mandatory spending targets. Now, as a physician, a heart surgeon who has dealt with a lot of quality initiatives that gave demonstrable results and, with regard to quality in the hospital where I practiced, I feel very comfortable in speaking for a number of physicians across this country and members of Congress in a bipartisan way who have deep concerns about IPAB and how it may affect the doctor-patient relationship. So I have and Mr. Ryan asked some intricate questions over some of the terms that were laid out, but I want to take it down to a very basic level that I think everybody in the room could easily understand. Could you please tell seniors if you plan to define the word rationing when you issue rules for setting up and implementing IPAB?
I am certain that that definition will be defined. And just to clarify once again, Congressman.
So you're saying, yeah.
IPAB cannot implement any recommendation. They are a recommending body. They don't implement anything. They do not control the Medicare benefit package. They do not control the spending package. And the last thing they can do, according to the law, is ration care.
But the IPAB recommendations go into effect unless a majority.
If Congress fails to act,
So why is the bar set
fails
so
to
high?
object to an
Why is the
IPAB
bar set so high in the law for Congress? 2/3 vote in the House,
votes?
2/3 in the Senate.
I think that there is a sense that Congress would object to issues or cuts that would harm beneficiaries. IPAB is prohibited from that in the outset. They cannot
again,
ration
this is
care.
like-
They can't shift
It's a
costs.
seeming contradiction, and but you are planning to define rationing in the implementation, in the rules.
I would assume we will make a series of definitions around what IPAB can and cannot do based on the law.
Okay, thank you. Let me change tracks now. In December of 2011, there was an article published in Health Affairs that stated that HHS knew in 2010 that the class program would not work. And it was noted that the Obama administration quietly negotiated a series of legislative fixes to the law aimed at maintaining the long-run stability of class. But these amendments were never discussed, certainly with this committee, and yet you waited until February of 2011, nearly a year later after the law was passed, to announce that class was totally unsustainable as written. And it seems as if your department knew for some time that the program would not work, and yet you did not bring this information that was requested forward to Congress. I have to tell you, having sent a number of letters on this, working with Senator Thune and others, I'm a bit irate that I first learned about these supposed fixes in a journal article, because we've been requesting documents since last March. However, in the documents we have received from your department, not one word mentions secret backroom deals HHS was making in early 2010. Why hasn't the department released this information?
Well, Congressman, I have no idea who was in the back room with whom and making deals, because that was certainly nobody from our department. What I can tell you is that during the fall, when there was discussion about the Class Act, and subsequently prior to votes, our actuary, the CMS actuary, did present open testimony that was available, casting some real doubt about the long-term viability of the program. As you know, when class was put into the law, I was directed to come to Congress before a program could be started.
Madam Secretary,
and
my time's
say
running
that
short.
it could
Let me
be
just-
solvent for
my
75
time's
years.
running
I did
short.
not do that.
I would just, in follow-up to letters we've recently submitted and in the past, I would like for your department to disclose details of HHS meetings and contacts with
Be happy to.
with CBO regarding class over the past 2 years.
Be happy to.
Thank you.
Mr. Roscoe's recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you, Madam Secretary. Madam Secretary, much of the HHS component of the White House budget deals with the President's health care overhaul. And I'd like just to have a conversation with you about that. Back in 2008, then candidate Obama promised that his premium or his plan would save the average family $2,500 on their premiums. And yet, according to Kaiser Health News, workers paid an average of $132 more for family coverage in 2011 alone. So the rhetoric didn't match the reality, did it?
Well, as you know, the plan is not implemented yet for families, so that will be the case, and Congressional Budget Office has actually estimated that families will save thousands of dollars once the exchanges are up and running, but the vast majority of Americans do not yet have access to affordable, available coverage. That's correct, and what you're seeing is a private market continuing to escalate year in and year out as they have for years prior to the Affordable Care Act being
How
passed.
about when the president said, if you're gonna, you can keep your health care coverage, if you like it, you get to keep it, and yet the reality is, according to Bloomberg at least, 9% fewer businesses are offering medical coverage than in 2010. There, the rhetoric didn't meet the reality, did it?
Well, again, Congressman, I think what you're seeing, it wouldn't have mattered if we had passed the Affordable Care Act or not. The private market is in a death spiral, has been in a death spiral, I would say, for 10 to 15 years, with more and more employers dropping coverage as rates continue to skyrocket. For the first time, I think we have an opportunity, and we've seen some pretty good news with new rate review going on in states across the country where double-digit rate increases are being withdrawn, where insurance commissioners are stepping up for the first time and making studies on actuarial soundness. So we're going to see some stability, but short-term, we will still see a very shaky market until we get to 2014.
All right. So back in 2009, President Obama told the American public that he was pledging to cut the deficit that we inherited in half by the end of my first term in office. That rhetoric surely didn't meet reality, isn't that right?
Unfortunately, as you well know, Congressman, the president inherited probably the worst downturn in the economy since the Great Depression.
I mean, I'm just trying to get the rhetoric and reality don't connect.
We are currently, I think, on a positive trajectory, but that is not likely to happen.
Turning back
which
to
is
what,
why he needs a second term.
Turning back to what, yeah, so we can keep doing trillion-dollar deficits. Turning back to your conversation with Congressman Teaberry a minute ago, you know, under this new health care law now, the Secretary of Health and Human Services has required a group of individuals to really violate a fundamental belief that they have. And you walked through and had a little bit of a discussion, but it wasn't really clear to me what's the remedy for the department if you've got an organization that says, look, with all due respect to the Department of Health and Human Services, we're going to follow our conscience. We're going to follow the fundamental belief that we think we have, and we don't agree with the interpretation and the guidance of the federal government. What is the remedy, Madam Secretary, that you have? So, for example, you've got the ability to fine these organizations $100 a day per employee. So let's say you've got a hospital. That's $50,000 a day. That's $1.8 million in fines. What else can you do to make them comply?
Congressman, I think that the issue of religious liberty is one that I and one that the President take very, very seriously. The issue of women's health coverage is also one that I take very seriously. And what we have proposed and what we will put into a rule and solicit comments on, and we're already doing outreach to a variety of not only religious employers but labor groups and women's groups and providers, is an accommodation so that the employers who have a religious objection to contraceptive coverage do not offer, do not pay for, do not refer people to contraception. On the other hand, their employees, whether she be a teacher or a doctor or a janitor, will have a choice about her own health care services and be provided according to the recommendations of the Institute of Medicine. I think that
Madam
those
Secretary,
two principles will be
Time has
upheld,
expired,
and I'm
so we do need
confident
to
we'll
wrap
find a
this up.
solution.
And I do hope that the Secretary will give as much weight to the First Amendment to the Constitution as to the other factors that you've mentioned. And Mr. Levin and I have consulted. There will be a series of votes about 3:15, so we're going to move into 3 minutes, and I'm going to have to keep very tight on the time here so that everyone has an opportunity. So Mr. Becerra is recognized for 3 minutes.
Madam Secretary, thank you very much for being here. I'm heartened some by the conversation here because while 2 years ago we had a very wrenching debate about trying to move reform in this country forward, now it seems like the concerns are around the edges about improving health care, and there are some concerns, but I think no one would deny that there have been remarkable improvements made to the system. You mentioned some. I know that there are over 54 million Americans who today are receiving expanded preventative health care services, some additional 30 million or so seniors who are receiving expanded preventative services. There are seniors who today have saved some $2 billion from not having to pay for prescription drugs through the donut hole, where they would have to pay out of pocket the whole cost. There are some 4 million small businesses today that can claim a tax credit for providing health care coverage to employees that before they wouldn't cover. There are some 72,000 children who have become newly insured because today there are protections against discrimination by health insurance companies against children who have pre-existing conditions. You mentioned the 2.5 million young adults who today have insurance because they're able to stay on their parents' insurance coverage. And there's some 20,000 American consumers who no longer have lifetime limits on their benefits. And surprise, surprise, what I think is very important as well, we've been hearing about how this reform would be a job killer. In fact, last year, some 300,000 jobs were created in the healthcare sector. 1 of every 5 jobs created last year was in the healthcare sector. So I think there are any number of good surprises, and we thank you for all the work you're doing to try to make it even better as we continue forward. A question to you, though, regarding the Medicare Advantage program, which you were asked about earlier. It seems to me that you made a very important point. We're not making any cuts to the Medicare Advantage program, the money that is paid to these private insurance providers. We're reducing the amount that they've been overpaid for years. I think you mentioned the amount of overpayment on average. Do you remember what that number was that you said the overpayment was?
It's about 13% more than fee-for-service, side by side.
And if I recollect, no senior would be deprived of health care through Medicare. They may find that their health insurer may decide to change the package of benefits a bit, but not the core benefits that Medicare requires or guarantees to every senior in America. Is that right?
Well, that's correct. And if anything, what we're seeing, Congressman, in spite of the accusations 2 years ago that somehow reducing this subsidy, which was built in by Congress years ago to overpay companies to encourage them to come into the market, reducing that subsidy would somehow have a damaging effect on Medicare Advantage. What we're seeing, companies do just the opposite. They are eagerly coming into this space, staying in the space. Medicare beneficiaries have choices in virtually every part of the country between fee-for-service and Medicare Advantage plans, and rates for Medicare Advantage plans are coming down.
All right. Thank you. Time has expired.
Thank you,
Mr. Gerlach is recognized.
Thank you, Mr. Chairman. Madam Secretary, I'd like to get back real quickly to the Medicare fraud issue, if I might. I'm over here. Thank you.
It's going across the front.
Yeah. No problem. The Department of Justice estimates the fraud problem to be about $60 billion a year. Congressman Neal mentioned the figure of $50 billion a year. You indicated you don't have a clear estimate of what that is. But let's assume it's $50 billion a year. Take that times 10. That's $500 billion over a 10-year budgeting window. And in your testimony, you indicate here that you have some initiatives going on within HHS that by conservative estimate would save $11.3 billion in Medicare Medicaid savings, as well as another $3.6 billion over 10 years through this comprehensive fraud fighting effort. So that's $15 billion over 10 years compared to a $500 billion problem. So why isn't there, and I think that's about 3% actually, so why isn't there more being done to really root out fraud? You said if we knew where it is, we'd go after it. We do know it's phantom billing. We know it's the criminal use of physicians' UPIN numbers. We know it's stealing beneficiary identifications for use, for criminal use. We know how it's occurring, so why are you only proposing only 3 percentage point reduction in fraud over 10 years?
Well, Congressman, I think that there is no question we need an all-of-the-above strategy, and that's exactly what we're doing, I would say, for the first time. We have a senior administrator who is, for the first time, charged with building a fraud and anti-fraud system throughout the program. We are, as I said, re-credentialing providers using the law enforcement tools, building a predictive modeling system, bringing the billing strategies into one central
Have you thought
area.
about?
So we're doing exactly
Have you
that.
thought about using a smart card system? Germany uses a smart card access system, which has eliminated fraud. The Department of Defense uses a smart card system to prevent fraud. Are you looking at that specific effort to tie beneficiary with the service provider at the time of the transaction to eliminate fraud?
We are. There are a number of strategies looking at a different kind of Medicare card that would be less easy to access and less easy to steal or share. There are about 50 different billing systems that currently take the card, so we're working actively with members of Congress.
Could you
We'd
share
be
that
delighted
information with
to.
us?
Certainly, sir.
Okay. Thank
And
you,
we
Secretary.
look forward to, if you've got new strategies, I think
We have a pretty
there's-
good idea. We'd love
we
to
are
share.
very eager. Yeah.
Thank you, Secretary.
Thank you. Dr. Price is recognized for 3 minutes.
Thank you, Mr. Chairman. Madam Secretary, welcome back.
Thank
I
you.
wonder if you ever relish the irony of a former state executive director of the Trial Lawyers Association heading the Health and Human Services Department. Does that ever cross your mind at all?
No.
Good. Some of us relish in that, that is the case. Mr. Lewis mentioned asked you what would happen if the President's health care law were repealed. And you went through a whole series of scare tactics that you revealed to the American people. And I just, you know better than that, Madam Secretary. There are wonderful, positive proposals and options to be able to get folks covered, to be able to solve the insurance challenges, to address some of the real costs that are driving physicians out of being able to take care of patients and driving patients away from being able to see doctors, that we ought to have an honest debate about. You mentioned, the President has mentioned over and over and over, if you like what you have, you can keep it. Grandfathered plans have been talked about. You said yourself, if you keep what you had in 2010, then you were eligible for grandfathering. The fact of the matter is that the law stipulates that if anything changes, if an employee is added, if there's a benefit that's changed at all, then one is not eligible.
That's
for
not accurate,
grandfathering.
Congressman, but I'd be glad to provide you the details. You cannot shift.
Look, I look forward to that. But that's in fact what the law
Well,
does indeed say.
it absolutely does not.
The
You can't
access-
shift costs onto beneficiaries, and you can't cancel
The access
benefits
to care
to the detriment of
issues are
beneficiaries.
huge for seniors, and they are being denied right now. You mentioned that 99.4% of physicians are seeing Medicare patients. Do you know how many are limiting the Medicare patients that they see?
I do not, sir.
It'd be an important number to know, because I would suspect
I can
that
tell you, though, we have an active monitoring system, and we are not getting complaints from people
the
who
hassle
have
factor is
trouble.
huge in health care. This is from one of your third-party administrators. This is denial of payment to a physician. You see, this is all that came in the mail. It says, "Dear provider, in January your facility filed 9 claims to Dr. Smith that suspended because the diagnosis code was not consistent with patient gender." What's he supposed to do with that? How's he supposed to figure out whether or not he's able to care for that patient again or not? This is the kind of hassle that is driving physicians out of the practice of medicine. The costs of health care are huge, huge challenges. The practice of defensive medicine, you know, is massive. What does your bill do to address the practice of defensive medicine?
Well, as you know, Congressman, there's about $50 million in various programs that are currently being funded, some of which look like they have great promise for
Any
future, so
liability
we are-
reform, any lawsuit abuse reform in your bill?
Well, there isn't liability reform that has
Isn't
to
that
take
how you
place at the
address
state level.
defensive medicine?
All right. Time has expired. Mr. Doggett's recognized.
Thank you, Madam Secretary. I come, as you know, from a state that officials, like some members of Congress, compete to come up with most critical comments about the Affordable Care Act. And yet, only yesterday, in our state capital in Austin, a state official testified that when this law is implemented, the percentage of Texans who have insurance will go up from 74% to 91%. And I hope he underestimated it, and we can get it higher than that. We've heard about, just now, about all these wonderful proposals that are out there, but Republicans have had more than a year now to advance the replace part of repeal and replace, and to date, all we have is one page of 12 platitudes that they adopted with enthusiasm last January. A concern that I have is what happens in naysayer states like Texas, which have so many uninsured individuals that could, and I hope will, benefit from the Affordable Care Act. Now, Texas, of course, when it came to those who were high risk, it took the no, we won't help approach, and you reached out, and a number of states, for different reasons, did not provide the high-risk pool and provided a network or a national network of high-risk pool for those states like Texas that said no. If Texas, which has sent back, I think, about $900,000 of the $1 million grant they got to begin preparing, if Texas is not ready in January, will you be ready to assure people in Texas that they can get access to the exchanges through the Affordable Care Act?
Well, Congressman, as you know, the way the act is written, states have the authority and the ability to not only set up a state-based exchange, but with resources and technical assistance provided by the federal government, if indeed a state opts not to take advantage of setting up a program at the state level, we are directed to set up a federal exchange. So the discussion earlier about additional resources at the Department of Health and Human Services are to do just that, to put the framework together for a federal exchange to make sure that Americans, regardless of where they live, will have access to the benefits that an exchange can provide come January 2014.
If Texas sets up a program, and like our Medicaid program, it's far inferior to that in other states, how much flexibility does the state have, or put another way, how likely is it that our citizens end up with a state program that provides much less in the way of coverage and benefits than those in other states under the announcement you made recently about these state exchanges?
And if you could answer quickly, because time's expired.
Well, I think the essential health benefit definition that you're talking about tries to balance a comprehensive insurance policy with affordability and with the notion that insurance is regulated at the state basis. So I think there are some underlying rules, what categories need to be covered, anti-discrimination, making sure that there's competition and no cherry picking. And then we hopefully will have some state flexibility reflecting the fact that those programs, those benchmark plans have been marketed and priced at the state and can be up and running.
All right, thank you. And I do want to remind my friend from Texas, we did have a health care bill that did not cost $1 trillion. It did cover pre-existing conditions and was the only piece of legislation scored by CBO as reducing health care premiums.
Is that something from this year that y'all have introduced, or you're talking about the alternative?
That was the alternative. Yeah. What's that? And it has been reintroduced by Congressman Herger, so it is currently in the legislative arena. Mr. Buchanan's recognized for 5 minutes.
Will we be marking it up anytime soon?
Mr. Buchanan has the time.
Thank you, Mr. Chairman. I want to thank Madam Secretary for being here today. I want to shift gears a little bit. I represent a district in Florida, but being the only member on Ways and Means in Florida, I want to talk about pill mills. Prescription drug abuse is a national epidemic. I've got an LA Times article here. Said death drugs now outnumber traffic fatalities in the U.S. Data shows 2009, 37,485 deaths. You probably know this, but in Florida, 7 people a day are dying from prescription drugs. There's more pill mills in Florida than McDonald's. They're saying the overall cost, one study has the abuse at $70 billion a year. I had 3 mothers come in. All of them had lost their son, I think daughter, about a year ago. I have a very good friend that it's actually, probably doesn't mind me saying, he was the CEO of the YMCA, which is large in our area. His son was weight training, hurt his back at 18. I think he was a football player, wrestling, and got on Oxycontin, and all of a sudden he's dead now, 6 months later. What are we doing, or what are you doing, what is your area doing to address this concern? I think, it used to be even in the workplace about, drugs and alcohol. Now these kids are getting, and I don't say it's just kids, but a lot of them are getting hooked up on these painkillers.
Well, it's a very serious problem, and you're absolutely right. The data is enormously alarming, where prescription drugs now have outpaced criminal drugs in terms of overabuse and deaths and injuries. We're trying to approach this, along with the private sector, in several areas. We've got efforts at the state level through the Medicaid program looking at overprescribed.
Madam Secretary, just because we're so short on time.
We would love to get you a full answer and tell you what's going on.
I've introduced a bipartisan bill.
Okay.
A lot of Democrats, I think every Democrat in Florida and all the Republicans on it.
We'd love to work with you on
I'd
that.
like to get you that bill and have you consider it and ideally support it.
Thank you.
The other thing is I just want to say in terms of Florida, it's been talked here about quite a bit today, is the whole thing of SGR and doc fix. We have a lot of doctors very concerned. I came in 2007. We've addressed the doc fix probably 5, 6, 7 times last year, 3 times roughly. I don't know how they run a practice, how you run a business. And a lot of them are trying to make long-term capital investments in their practices. They said, we can't do it. The banks won't even support them. We really need to have you guys provide some leadership on this because obviously it's not getting done any other way. But the president and the administration really needs to step up and address this because in Florida, health care is so critical, and we've got obviously more seniors than most, and health care is critical to our seniors. We need good doctors and be able to keep them and pay them.
All right, time has expired. Mr. Smith is recognized for 3 minutes.
Thank you, Mr. Chairman. Thank you, Madam Secretary. I want to touch on a few budget-related health care items, the first being critical access hospitals, and the second being the Medigap plans, and then also this new fee increase at FDA to cover a 17% increase in their budget, if time allows. But regarding the critical access hospitals, as you know, and I think you can appreciate service in a rural state, how important health care is, and these critical access hospitals really are modest gateways to health care, or entry points to health care. And the President's budget has proposed reducing the reimbursement to critical access hospitals. Can you tell us kind of the background to that strategy and what the impact might be?
I can't do it with any precision in terms of the years that it would hit. I share your concern about the importance of critical access hospitals, and I know in the overall payment strategy, we're continuing to pay an increased amount to critical access hospitals as we move forward, recognizing that often they are the only service provider in an area and that it's essential to keep them there. But I can get you a more detailed answer in writing, sir.
I know they're very concerned about the proposed reduction, and so I do look forward to hearing more on that. Now, the budget also recommends that seniors with the Medigap plans, which have near first dollar coverage, pay a surcharge equal to roughly 30% of their Medicare Part B premium. Can you speak to why the President recommended this policy?
Well, I think there's a market strategy that indicates having some investment among consumers in the Medigap plans is actually a positive step forward. So he is following some recommendations that have been made over time and looking at some of the market strategies that seem to be effective.
So, I mean, what do you see the impact being? I know that, I hear from seniors concerned and obviously providers as well, what that impact might be.
Well, I think that there are a variety of plans, many of which, as you know, do not provide $1 coverage from the outset, and we've looked carefully at the health outcomes, measuring the plans. This is seen as a way to not only produce some revenue in the long run, but also discourage what may be redundant use of services and have some strategies in place that actually are more cost effective. But there are a variety of plans that currently, without any impact on beneficiaries, don't have the $1 payment by the company.
All right, thank you. Mr. Thompson's recognized.
Thank you, Mr. Chairman. Madam Secretary, thank you very much for being here today and for your willingness to stay as long as necessary to answer all these questions. It's refreshing for
There's a hard stop at
that-
3:15 with our vote, so we don't have all day.
Do I have 12 minutes or 3 minutes?
3.
Madam Secretary, you were kind of cut off when you were speaking to the issue of medical liability and what some of the promise has shown. Is there anything else you wanted to add to that?
Well, I can tell you, and I'll just make it very brief, we are encouraged under the Agency for Quality and Research. We were directed to put some dollars out to look at possibilities with hospital systems and provider groups that actually are working in the market. And I think we will be coming back to Congress very shortly with a robust set of options, but we're encouraged by what we're seeing, some programs that really work. The Sorry Works really does settle cases and seems to greatly reduce litigation.
Thank you. And I'm encouraged by what I hear in my district in regard to the Accountable Care Act. People are glad that they can't be cut off from their insurance if they get sick. They're glad their kids can stay on till they're 26 years old. Seniors are very, very happy that the donut hole is closing. And just today I had a major California insurer in my office who was very complimentary about the things that we put forward in healthcare reform. And they've got some real good statistics as to how that's benefiting California consumers as well as consumers in other states where they operate. So it's not all doom and gloom. I think we're seeing some really positive and refreshing success as a result of this bill. I'm particularly encouraged by HIT. Everybody I talk to at home is glad that we're moving to health information technology, and they're seeing the improvements and they're putting it in place. Can you discuss why health IT is important and what the expansion is looking like?
Well, I think there's some great news there. Again, we have now twice as many doctors and hospitals using electronic health records as we're using them 2 years ago. That's a huge uptick, and we think that trajectory is going to continue. What we know by looking at the information is that having an electronic record is the best way to coordinate patient care. It enables providers to eliminate duplication, lower medical errors, and provide a much more patient-centered care in that patients actually own their own information, can look at their own information, monitor their own information. What we're also seeing, Congressman, is a huge number of jobs being created, not only in the software companies building these systems, which often are companies under 50, and any one of them could be the next Google or Microsoft, but the number of health IT workers.
I'm
that are
afraid I'm
now
going to have
being
to stop you
deployed.
there.
Thank you very much.
We're just running short on it. Mr. Schock's recognized for 3 minutes.
Thank you, Mr. Chairman. Welcome, Secretary Sebelius.
Thank you.
Do you agree with the effort to lift the ban on using federal funds on lobbying campaigns?
To lift the ban?
Correct.
We just recently got a proposal in the 2012 budget, which we're in the process of implementing. So I don't know anything about the
Well, my
proposal to
understanding is
lift the ban.
the President's budget lifts a long-standing prohibition on using federal funds in lobbying campaigns.
I don't know anything about that effort. I do know that language added to our budget in 2012 went well beyond what has been the longstanding policy. And I know there are members of Congress who have expressed some concern that in looking at the 2013 budget, we would look at that expanded language, which doesn't, the language that has been in place for a long time affects federal agencies. The language in the 2012 resolution that was reached actually reaches down to grantees and stakeholders and implies that their activities can no longer be engaged in any kind of activities to change public policy. So, but I'm not involved in an effort, and I'm really not aware of an effort to lift the ban. I'm sorry if I'm not answering your question.
Well, no, you are. In fact, I'm glad to hear that you're not involved in that. And my question really targets the grantees, which you mentioned just a moment ago.
Which is brand new language. This is not a long-standing policy. It's brand new language in 2012.
to allow them to use federal funds?
No, the ban that we are now expected to implement reaches down into grantees and their activities at a state or local or municipal or school board level.
So
It doesn't
folks who
have-
are receiving dollars from the federal government, grantees who may be currently using them for lobbying campaigns.
Well, to
once your
change
rule-
public policy.
Well, okay, to change public policy, we call that lobbying, but okay. People that are using that federal dollars to change public policy will no longer be able to do that once your rule is fully implemented.
That's my understanding, yes, sir.
Okay, thank you. Second, I have a question about the agency's desire to change the time period for biologics. And my understanding is there's an effort underway to change for pharmaceuticals that are biologics based from the current 12-year time period. And I'm just wondering if you could speak to why that is, you believe, important.
Is there a legislative proposal? I'm sorry, I want to make sure I answer the question accurately. Yes, sir. I think that I just wanted to make sure what the year span was, and this has been under discussion for a while to lower the strategy from 12 years to 7 years, which I think is seen as an assistance, frankly, to consumers to get products to the market in an affordable fashion in a much more timely basis.
All right, Ms. Jenkins is recognized.
Thank you, Mr. Chairman, and thank you for being here, Madam
My
Secretary.
Congresswoman, nice to see you.
That's right. The Affordable Health Care Act makes clear that health insurance subsidies are only available to individuals and families enrolled in an American Health Benefit Exchange, which is defined in the law as a state-based exchange. And further, the law requires that in order to be eligible for exchange subsidies, the individual must be enrolled through an exchange established by the state. That's a quote. And in response to Mr. Levin's question, you explained that it's clear that many states will not set up exchanges. And as you know, the law does not allow subsidies to flow through federal exchanges. However, back in August, the IRS issued a proposed rule allowing premium subsidies to be made available in all exchanges, whether state or federally run. The IRS commissioner responded to a congressional letter on this matter stating, and I quote, "The statute includes language that indicates that individuals are eligible for tax credits whether they are enrolled to state-based exchange or a federally facilitated exchange." Now, I can't find the term federally facilitated exchange in the healthcare law, so I'm just wondering exactly where in the law is the term federally facilitated exchange, or what specific language authorizes the administration to allocate subsidies via the federal exchange.
Congresswoman, I'd be glad to get you that answer in writing. There's some very detailed legal analysis and also a variety of statutory language, so I'll be sending that back right away.
Okay, because it appears, and I'd just be curious if you would agree, that essentially the IRS is amending the healthcare law through the regulatory process.
No, I don't think that's accurate at all, but I will send you the statutory references and the legal interpretation.
Okay, because if the law provides it's only federal, it's only allowed for the state-run exchanges. and
I
yet
will be
we are-
happy to answer this question in detail. It has been analyzed and looked at. You may disagree with the analysis, but I will be delighted to get you the language in the statute and the legal interpretation of that language.
Okay, because those of us in Congress, I think, get a little defensive when our constitutional authority to write tax policy is taken away from us and imposed through a regulatory agency. So thank you. I yield back.
Thank you. Mr. Larson.
Thank you, Mr. Chairman, and thank you, Secretary, for being here. Let me say that I am very proud of the Affordable Health Care Act, sometimes derided and called Obamacare. But I kind of like that as well because it's pretty clear that the President does care. And at the end of the day, that's what it's all about, even here on this committee where sometimes we appropriately, and good members on both sides of the aisle, deal with all of the economic issues and all of the green shade issues, et cetera. But what an honor to have a person of your capability, both a former governor who knows how to administrate and get to solutions, and also a woman who understands the incredible balance that needs to take place in this day and age. And finally, because of the Affordable Health Care Act, bringing into parity the women's health issues that you talk about. I thank you for making and moving responsibly the accommodations that your agency has to Catholic Charities and to our university systems. And it's great to see the Father Jenkins and the Affordable Health Care people all coming forward and praising your efforts in this area. But at the core of this, when you look at these issues where 15,000 women still are susceptible to cervical cancer and die every year, you begin to appreciate and understand the importance and significance of this, as well as people and constituents who say to me every single day, I don't care whether you're a Democrat or a Republican or an independent. I have a 19-year-old son that needs a liver implant. Please keep that act in force. How many more people do you think will benefit by this? People want to see us about solutions. I commend you and your agency for being about solutions.
Thank you.
Thank you. Mr. Paulson's recognized for 3 minutes.
Thank you, Mr. Chairman. Thank you, Madam Secretary, for being here as well. We've had a chance to talk in the past about some medical device issues. I want to just follow up and ask a question here. All things being equal, do you believe that encouraging the use of lower-cost alternatives like generics, generic drugs, for example, makes sense for both the patient as well as the consumer as a way to help lower health care spending overall? I assume that's a goal that you would generally agree with.
I think the more consumer information that people have about effective outcomes and prices is great. Absolutely.
And I think we also, you'd probably agree, we have a shortage of primary physicians.
We do. We're
currently.
filling that pipeline thanks to some of the resources in the Affordable Care Act, but we do.
Well, I should just share that one of my chief concerns with the new health care law is a provision in there that does not allow those that have flexible spending accounts or health care savings accounts to access the purchase of over-the-counter medications unless they have a doctor's prescription. And I've certainly heard from a lot of suburban moms and constituents in general that have been frustrated about, they get Claritin for their kids or Advil, whatever it might be, and so they're sort of resort to having to visit the doctor or the primary physician to get a prescription for Advil or some of these generic drugs. And so it's not accessing a lower cost alternative to lower health care costs. Do you think that the prohibition that's in the current law should be changed or repealed, or would you be willing to work to modify that to the benefit of more consumer-driven health care for those over-the-counter generic drugs?
Well, I think, Congressman, the notion about the provision was not to discourage the purchase of generic drugs. It was to recognize that health savings accounts are often for health needs that aren't being met. So the same way that most insurance coverage doesn't cover over-the-counter medicines, the health savings account was brought in line with what insurance policies currently have in place. And clearly people hopefully will continue to buy aspirin and buy a variety of over-the-counter drugs. They just won't use their health insurance policy or their health savings account to do that.
Well, and I just want to mention, too, because it's the flexible spending account as well that's an issue. Again, these are their own health care dollars. They set them aside through their employer's plan. And, I have one constituent here who said this rule is really a burden for consumers as well as physicians, since additional office visits are required to get an over-the-counter medication prescription. And these FSAs really are a valuable tool. I mean, they're used by a lot of hardworking Americans to help manage and hold down these out-of-pocket costs. And so this is a significant issue where I don't know if it was overlooked in the concept of the new law passing, but both FSAs and HSAs, this is definitely an issue that I think we should work on.
Well, I would be glad to talk to you further about that.
Okay.
Sure.
Thank you.
I yield back.
Mr. Marchand is recognized.
Thank you, Secretary. I'm very concerned about the Texas Women's Health Program's current Medicaid waiver status. This program was first implemented in 2007 and must receive HHS waiver approval. It is currently authorized by HHS through the end of next month. The program currently provides services to over 100,000 Texas women on an annual basis. I'd like to ask 3 or 4 questions, and if we don't have time for you to answer, I would appreciate you submitting an answer in writing to me. What is the current status of the HHS's review of the waiver for the Texas Women's Health Program? Question number 1. Number 2, please tell us about the HHS main reasoning behind its review for the current Texas waiver request. Is this reasoning consistent with other waiver requests for similar health programs from other states? In the past, hasn't HHS allowed states to make the decision about who can be a qualified provider? Has HHS ever tried to overturn a state law about who can be a qualified provider? And the last question is the waiver being refused because of a current Texas law that prohibits state funding to go to Planned Parenthood?
Well, Congressman, I would be glad to answer those questions in writing, but let me just say, just as a 30,000-foot view, this ruling is very consistent with what has been Medicaid policy around women with a family planning waiver to be able to choose a provider. It is consistent with the information we gave to Indiana in June of 2011. We've made it very clear to Texas we are eager to have this program continue. Their women's health program provides coverage to, as you say, about 183,000 women in Texas. That's very important, and we want to work with them around the policies that are allowable to move this forward. But I will be glad to answer your specific questions in writing.
Okay, thank you.
Thank you. Mr. Blumenauer is recognized.
Thank you, Mr. Chairman. Thank you, Secretary. Let me just say, coming from one of those states that are low cost, high quality, our legislature just passed legislation. Governor Kitzhaber, probably the best qualified.
I think he's living in my office, but.
Well, we just want to say that there's a commitment top to bottom to take advantage of the potential of this legislation, and I think we've demonstrated billions of dollars of savings in the past, and we hope to have flexibility for people that want to charge ahead on this. I think you were too kind earlier to Congress when people talked about the fast-track provision in the legislation. I mean, it seems to me that it's Congress that has been spineless and has had to have it both ways. They want to cut costs. They don't want to say no to anybody. And the procedures that are here in this legislation don't have any restriction on majority in the House. In the Senate, where it appeared to take a 60-vote threshold to literally do the most mundane of business, it seems to me that putting that in here so there wouldn't be the goofy procedural thing that has driven Republicans and Democrats alike in the House crazy in the other body, it still makes us responsible. We have a chance. I thought you were too kind, and anybody who is concerned about it ought to look at what's written. I think it's very, very reasonable. I identify with some of the comment my friend Mr. Gerlach talked about smart cards and moving forward. I think there are techniques here that we're personally, I'm very interested in pursuing. And indeed, what can be done under flexible savings account, I think, is different than drawing on insurance, not just for over-the-counter medications, but also some types of physician services that aren't now eligible, that seem a little goofy to me, and I will follow up with it just a moment with the piece in writing. But I wanted to go back to the contraception controversy. It seems to me that for years there were Catholic institutions that had provisions exactly like this in their health care coverage, as well as a number of states that have been doing this for years without controversy. Is that correct? And do you care to elaborate on that at all? This mystifies me that some Catholic institutions have been doing this for years, and now all of a sudden it's a threat to religious liberty.
Well, I don't think there's any question that there are a variety of religious facilities Catholic universities, hospitals, systems, others who have long offered contraceptive benefits to their employees and let the employee pick and choose whether or not to access those benefits based on his or her own faith belief system, some to comply with state laws in place, some in states where there wasn't a state law in place.
All right, Mr. Berg is recognized.
Thank you, Mr. Chairman. Thank you, Secretary, for being here. First of all, I'd like to echo my colleagues' concerns about the President's health care overhaul with the unelected IPAB board and also the regulatory encroachment on religious freedoms. Having said that, coming from North Dakota, I think a state with high access and affordable health care, one of the things that I'm most concerned about is critical access hospitals. North Dakota has 36 of those, and my understanding is that this proposal would impact them by about $1.2 million. And with almost 20% of our population in rural North Dakota, or excuse me, in rural America, I'm concerned about that access. And so, obviously, coming from Kansas, I understand you have many of the same issues.
You bet.
So my question really relates to what process did you go through in terms of consulting and including the rural practitioners with this proposal that's presented?
Well, I think, Congressman, I do share your concern about access in rural areas. It is a critical issue and one that I did see in Kansas. I can assure you also that our head of one of our key agencies is a fellow North Dakotan, Mary Wakefield, who each and every day reminds us that every policy as we implement this, and she informs a lot of our policies, need to be done with rural health care providers in place. I think we are confident that this proposal doesn't jeopardize long-term access because there are other funding streams that increase in this proposal, but we're going to watch this very closely because access in a rural area is critical in a critical care hospital.
I'll yield back.
Ms. Black is recognized.
Thank you, Mr. Chairman. Secretary, we all know, and it has been said a couple of times here before, that the President did say prior to the passage of this legislation, if you like what you have, you can keep it. And we're continuing to find out that that is not true. I do want to point to the fact that I have been reading this, and I'm almost finished with it, but I am astounded with the number of times that it says in here, the Secretary shall establish, the Secretary shall promulgate rules, shall develop standards, the Secretary may develop and impose appropriate penalties, and over and over and over again, a lot of authority is given to you as Secretary, Madam, and where I'm concerned is knowing that there was a Senate hearing where you said you did not consult with the bishops before the administration announced a change in the conscience protections. What can we be assured as we move forward that you're going to have an open rulemaking process and that you're going to involve those entities that are going to be impacted by these rules and regulations that need to be written?
Congresswoman, I didn't talk to the bishops because the President talked to the bishops, and I felt that that was sufficient since he is my boss. We did promulgate a rule in July. We got 200,000 public comments on that rule. We consulted with a whole variety of people in addition to those comments. So this was a very open process. It was a very inclusive process, and I can guarantee you it was a very robust dialogue that went on between July, when the initial rule was put forward, and January, when it was finalized.
And in those comments that you got, were there comments from the entities that were going to be directly affected by this?
Absolutely. There were comments from providers, there were comments from women's groups, there were comments from labor organizations, there were comments from university presidents, from religious leaders, from charity groups. We heard from a whole lot of people. 200,000 comments. Yes, ma'am.
Well, it doesn't seem.
And that was a very open
And
process.
I hear what you're saying, that the President was the one who met with the bishops and
yes.
Had those comments, and I guess there was or maybe not a communication between what was said to the President and then what eventually came out on this, because the bishops were quite surprised to find that this ruling, which they were told, from my understanding, that this was not going to occur and there would be no effect on the way in which they were operating. Again, going back to the President saying, if you like what you have, you can keep it.
Well, as you
Obviously,
understand,
that's not
churches
true.
are totally exempt from this ruling. That has been the place. So the bishops and the churches that they run and their church affiliates are exempted from this rule.
Well, it seems to me, again, we're having our freedoms taken away from us, and I hope, not going to see that continue as we go through this rulemaking process, and there are a lot of rules to still be made.
All right, Mr.
Thank you,
Pasquarello is
Chairman. Yield back.
recognized for 3 minutes.
Thank you, Mr. Chairman. Madam Secretary, it's obvious that the President recognizes that we cannot simply make draconian cuts to solve the deficit problem. Sounds good. It's an oversimplification, and it doesn't work. It only adds to the deficit later on. New payment models, more efficient delivery of care, and curbing Medicare fraud are all better options than transitioning to a voucher program that shifts the cost to beneficiaries. Nobody's denied that. I personally believe we can balance the deficit without cutting Medicare for seniors and breaking our promises to them. My question is, while the Republican budget proposals shift the burden of Medicare to Medicare beneficiaries by transitioning to a voucher program, how does the President's budget cut costs without changing the fundamental structure of Medicare or cutting benefits?
Well, Congressman, the President, both as part of the Affordable Care Act and then again in this budget window, has proposed I would say, a gradual slowing down of some of the cost increases. We've talked about Medicare Advantage. This budget contains some additional proposals dealing with drug costs, that Medicare should take advantage of some of the drug rebates that are currently in place in the Medicaid program, which would save significant dollars, additional fraud efforts. But the basic package of benefits that is a guarantee to seniors and those with disabilities, the 48 million Americans who rely on Medicare day in and day out, is not harmed by this. And in fact, what we're seeing is care improvements and beneficiaries. Every time that the dollars go down and premiums go down, beneficiaries actually have more money in their pockets. So seniors have actually had a great deal of relief, those in the donut hole, from the closing of the donut hole. As Medicare Advantage premiums go down, that saves beneficiaries money because they pay less of their copay and their share of those costs. So it has been a win-win situation that slows down the growth trend, which was significantly ahead of inflationary costs, and yet protects the guaranteed benefits for the beneficiaries.
Thank you. Mr. Reed, last but not least, is recognized.
Thank you, Mr. Chairman. Thank you, Madam Secretary.
Certainly.
Madam Secretary, I just have a very direct question for you. On the individual mandate penalty, is it a tax? Yes or no?
I am not a lawyer, so I'm not equipped to answer that question.
So when the OMB director stated before the House Budget Committee that the individual mandate penalty is not a tax, President Obama has publicly stated that it is not a tax, yet your legal briefs in the Supreme Court case in writing have submitted on your behalf, because you're a named defendant in that proceeding, the practical operation of the minimum coverage provision is as a tax law. Do you agree with your attorney's assertion to the Supreme Court that it is a tax provision?
I think it operates the same way a tax would operate, but it is not per se a tax.
Okay, so it's not a tax, but it operates as a tax. That's your testimony to us.
I am not a lawyer. I do not want to try and quote the legal briefs. I would defer to my legal team, and I'm not really going to try and parse this back and forth.
Okay. With that, I'll yield back. I know we have to vote, Mr. Chairman.
All right. I want to thank the Secretary for her time today. We do have votes on the House floor, and with that...
Thank you, Mr. Chairman. Take good care of Traverse City.
I will.
Okay.
And Leelanau. And with that, this hearing is now adjourned.